Hi, welcome to the Catholic Corner. I'm Monsignor Walter Nolan. My guest today, and actually next week also, is a very, very dear friend of mine, Judy Persichilli. Not only is she a great friend of mine, she's a wonderful, wonderful human person. And I mean that with all my heart. Judy has done so many great things. Right now, Judy's the interim president and chief executive officer of Catholic Health East, Trinity Health. Whew, boy, that's a big, big job. And you know what? She does it so well and so beautifully. Catholic Health East, Trinity Health, is one of the largest multi-institutional Catholic healthcare delivery systems and the third largest not-for-profit health system in our beautiful country, the United States. It serves people and communities in 21 states from coast to coast, 82 hospitals, 89 continuing care facilities, and home health and hospice programs. Guess what? Provides nearly 2.8 million visits annually. And you still keep smiling. Wow. Formed in May 2013, it has an annual operating revenue of about $13.3 billion and assets of about $19.3 billion. It returns almost $1 billion to its communities annually in the form of charity care and other community benefit programs. Employs more than 87,000 people, including 4,100 employed physicians. Catholic Health East, Trinity Health, is committed to those who are poor and underserved in its communities. And you know what, folks? They don't change the mission. That mission has been there for a long time, and their option for that poor is just marvelous to behold and wonderful to be a part of. Judy, it's great to have you on the program.
It's good to be here.
God bless you. Tell me a little bit, we're going to turn the clock back a little bit. We started you off way up here. let's bring it back. Nursing school, nurse.
I started out as a nurse. I'm really proud of that.
Oh, you know.
I tell everybody when I get up in the morning and I look in the mirror, I still see a nurse.
Yeah.
I went to St. Francis Hospital School of Nursing, had the most wonderful experience there. It was a privilege to be there. Worked in intensive care for a while and then decided to go back to school. Got a Bachelor of Science in Nursing from Rutgers University, and thought, I'm in school, let's keep on going. I got a Master's in Administration at Rider University. Loved all of my education. I did not know that the trajectory would bring me to this point, but I will tell you a little story. I had graduated from my undergraduate. I was working at St. Francis, developing a quality assurance program, and I thought for sure that my career in healthcare was going to be about quality. I loved the work I was doing, making sure that quality standards and safety standards were upheld throughout the whole hospital. And Sister Agnes Marie, who was the administrator at the time, came and talked to me one Friday, and she said, you know, Judy, there's a new reimbursement scheme coming up, and it merges clinical information with financial information. I said, well, that's very interesting, and in the back of my mind saying, why is she telling me this? She said, I want you to go work in finance. And I said, excuse me? She said, well, I hired all these CPAs, but they don't have clinical knowledge. I want you to work in finance. And I said, sister, thank you, but no thank you. Quality is my life. I like wearing my white dress, and then we were wearing hats,
remember that?
the caps.
I love them.
This is who I am. And she said, well, you think about it over the weekend. And I like to tell the story that I came in Monday, and my office was moved.
So much for your decision.
And so I worked in finance. And that really was what I call an inflection point in my career. It moved me into more of the administration side of things.
But you jumped over the fact that you were a cheerleader in your school and all of those wonderful stories that you told me.
We had a really,
you're still a cheerleader.
We had a really good women's basketball team.
Let me tell you, you still kind of gather the troops and cheer them on. So you've worked in the administrative end for a long time. You served as president of St. Francis Medical Center, executive vice president, Northeast Division of Catholic Health East. Tell me, what led that big decision, beside the story you just told me? All of those moments of life just never go away.
You know, as I looked at the way hospitals were managed back then, it was always interesting to me that people without clinical knowledge were making decisions about patient care. And I thought it was really important to be able to get a seat at the table, to be able to make decisions about patient care that would uphold, again, the quality standards that we have to stand behind, and to carry out the mission and be creative about how we do that. And at the same time, always making sure that we gave the best patient care. So I would look at some of the administrators and think, you know, I could do that.
Better?
I might be able to do that. So it really was with the eye always toward our mission and, you know, what do the patients really need? How can we serve the community and do it well?
And mission's important, isn't it?
Mission is important.
Mission is important. What, healthcare's changed a lot since Nurse Judy was was beginning her career?
Yeah.
How has healthcare changed? I mean, what are some of the changes that you saw and witnessed and probably leadership roles in?
Well, when you look at healthcare when I first started, it was not really that difficult, nor was it really as effective as it is today. We didn't have a body of research which we call evidence-based medicine. And so a lot of it was the science, but a lot of it was the art. And then you put technology on top of that and the changes that technology and drugs have made. And suddenly, things that I saw, you know, if you went into the hospital to have your gallbladder removed, when I first started, you stayed 2 weeks to recover. Well, now gallbladders are removed minimally invasively, and you go home the same day. And it's no longer a foregone conclusion that if you need heart surgery, that your chest is going to be cracked and opened up and your vessels repaired. We can do that robotically or minimally invasively with the appropriate patient at this point in time. So the technology has really taken over, and it's been somewhat disruptive.
I think back. I think back to myself and a bunch of the guys I went to high school with, and all the, standing on the street corner and talking. We never dreamed some of these things today that are happening, and they're happening just so easily today. Healthcare. Why Catholic? I mean, I know you're Catholic, and you're a great Catholic.
Well, I like to tell people that, you know, I've been in Catholic healthcare. I think almost all my career, really, about 45 years, and it was first by accident. St. Francis Hospital School of Nursing was the school of nursing to go to. I went to high school in New Brunswick, but if you got into St. Francis, that was considered the top school. So that was by accident. It was really because it was such a good school. And then it really became a really definitive decision of mine to stay in Catholic healthcare, primarily because of its preference for the poor and the vulnerable. The people who need us the most, we need to be present to, and we are. So I've worked at St. Francis, I've worked at St. Michael's up in Newark when I went to undergraduate, I worked at St. Peter's in New Brunswick. I was always drawn toward primarily urban health care and outreach to the poor and the vulnerable because that mission became very important to me personally.
Isn't it harder today even to fulfill that mission? I mean, it just seems, listen, we've had poor all the time, and I guess we were poor kids too growing up. But nowadays it just seems harder for administrators or doctors, et cetera, to keep that mission alive.
It's really a challenge because at the end of the day, healthcare is a huge business, 17% of our GDP. We have to own the fact that it's so expensive and that the outcomes are not as good as we would like them to be as we compare ourselves with other nations. And it is a huge financial strain to continue taking care of the poor. But that's where the mission becomes alive because I'm always amazed that in our Catholic hospitals, the tenure of our employees, our colleagues, our greatest asset, the people we rely on to carry out the mission, their tenure is longer than in most secular hospitals. They stay, and I like to tell the sisters because their DNA is the mission and the DNA is in the walls of the institution. So it's challenging, but it's also very creative.
You know, Judy, those of us that have a part of hospitals like that, you breathe it, you feel it. You know, you can't maybe write it on the walls, but it's there, and that's a marvelous, marvelous thing. Your faith, I know you're a woman of faith. How has your faith, impacted your decisions, and how has your decisions impacted your faith?
Well, you know, it's really interesting. I think you grow into your faith and your faith beliefs, and you can be raised Catholic and you can go through all of the rituals, but at some point, You really need, especially in administration, and I tell younger people this all the time, you need to get out of the mechanics of it and learn the art of reflection. And I do that, whether it's at the beginning of the day or at the end of the day. When people ask me, what do you think about? I reflect, and it has nothing to do, it may be a passage that I read, because it really deepens who you are as a person and how you approach your work. So that's been kind of a change for me as I've, philosophically, as I've grown older, and it deepens your faith in the understanding there's something more than what we see every day. You know, your life isn't, your life has changed at the end of life, but it isn't ended. And when I was doing direct care, particularly in intensive care, that resonated with me every day, or else you couldn't do the work that you do. You can't see the pain and the suffering, and you can't make sense of it, in my opinion, if you don't have a faith foundation about what that's all about.
And then you see the miracles.
Every day.
You know, and not just miracles of health or change of health, miracles in people's attitude, their expression, their own growth, and it is in itself a miracle. I mean, when you talk about you don't learn it in a book. You learn it really, I think, with the experiences of love and joy, and then when you see people like yourself and doctors, nurses, spending hours, you know, and you think, yeah, they could be home watching the football game or something, and yet they give their life just to bring more life to someone else.
I like to say that the colleagues and the doctors, the nurses, everyone that works in a hospital and in healthcare, they put aside every day their own individual burdens, and they come in to help other people. Yeah. That is a privilege just to walk the journey with them. Yeah.
But you know, then when you see somebody like down the mall that you know was in the hospital, 6 months ago, and now they're, it's you just inside you glow. How about our church and healthcare? How does it interact, with each other?
Well, it's really interesting. Catholic. There's about a little bit over 600 Catholic hospitals in the United States out of the 5,000. We care for it's about 12%. We care for millions of people every day. We have 500,000 full-time employees, 250,000 part-time employees, and most of the hospitals that we work in, now I'm talking a lot about hospitals, with healthcare reform we're moving to healthcare, wellness and prevention, but when I talk about hospitals, most of the hospitals were owned by congregations of sisters that were called by bishops over a century ago to come to foreign lands. They came from Ireland, they came from England, and they came from foreign lands with 50 cents in their pocket because a bishop called and said, I need help to take care of the immigrants in New Orleans. I need help to start a school in Trenton, New Jersey. So the Sisters of St. Francis came on horseback to Trenton to start a school, and they realized what was really needed was a hospital. And they started going door to door to take care of people. I say they were the first home health agency. And then they decided to raise money to build a hospital. And the hospital that exists today is on that same site.
St. Francis.
Yeah, the same site that was started over 125 years ago. So the congregations of sisters in relation to the church started these hospitals. Now, we're not owned by the church, but certainly we are a church ministry. That's why we exist. Our mission is important to us as a church ministry, and Catholic identity, how we celebrate the rituals, how we bring forth the charisms or the gifts of the sisters who started these hospitals so many years ago, is part of what we do. Having pastoral care services, spiritual care services, mission services, mission integration services. It's really important for us to have formation programs so that our employees and our managers and leaders learn our connectivity to the church and the Gospels and the gospel message and why we exist. So we're very tightly aligned, obviously, with the hierarchical church, or what I call the institutional church. But in fact, most of us are owned by congregations of sisters.
I I wish more people could understand and know that history. I mean, even ourselves, we know the history, but I mean, to kind of every once in a while, just sit back, close your eyes, and just kind of picture what the streets look like, what the sisters look like, and how many hours they probably worked for, 10 cents a day or whatever, or nothing a day. And to kind of say, we are part of that history. And how do we bring it into the future? Because things have changed and things are going to keep changing. And how St. Francis has evolved. Mm-hmm. I mean, you've seen it evolve, I'm sure, in so many different ways. Even the building, it all. But how do the buildings have to get evolved even more, or are the buildings now changing into something else?
Well, I think the buildings are less important than the people in the community. Yeah. When we say in our mission that we will be a healing, transforming presence in the communities we serve, what we're saying is that we will fill the gaps. We will identify through community needs assessments what's needed. And we're not going to be stuck in the past. The one thing the sisters have taught us is how to go forward and also how to let go. And sometimes you have to let go of, a special loved program so that you can put those resources into something that's needed, that's not duplicative of something that someone else is doing. So the whole process of community needs assessments, knowing what to let go of and how to move forward is very important. And we need to move forward. Helping our communities regain the health, particularly in urban environments, regain health or gain health that they haven't enjoyed in the past. And that's a focus on population health, the gaps, and moving back to where we started, into the homes, into the communities, less so into the hospitals. That's a huge change in the healthcare in the United States today, a huge change. But it's occurring, and I'm really happy it's occurring, because I think we can make populations healthier and keep them out of the hospitals, not draw them into the bricks and mortar.
And that's what it's all about.
That's what it's all about.
It's almost like we win to lose to win again,
That's
or
right.
something like that.
That's right.
I think it was Pope John the 23rd, and I'm quite sure it was him, who said, with his own insight, he said, the past is beautiful, but let's not live in the past.
Not live in the past.
He said we have to really see, what our faith is now in the communities that we serve now,
Yeah.
and that's exactly what you're doing. But difficult, huh? How difficult is it today for a hospital, let's say St. Francis or anyone, to stand by itself?
Well, that's why we have a system. That's why CHE came together 13 years ago. Trinity Health came together 13 years ago, we brought together organizations on the East Coast. They brought together organizations primarily in the Midwest. But the reason we came together was the sustainability of the Catholic healthcare ministry into the future. We felt we would have a stronger financial foundation if we came together, and it's proven to be so. Just from purely economic perspective, financial perspective, we are a very strong organization. Well, St. Francis and Trenton gets protection from that sustainability. That doesn't say that they shouldn't change and that they shouldn't reach out and be more essential to the community they serve, which is primarily an urban community in Trenton. But they have a foundation that will help them do that.
How does that work? How does it help, like a hospital, Catholic hospital in Trenton and Catholic hospital in New Brunswick or Maine, or do they have a purchasing power or
Sure.
share expertise?
Yeah, the first thing we brought together all the transactional activities, and that's supply chain purchasing, all the intellectual capital that we've learned from one another in terms of taking care of patients better is brought together in collaboratives for the clinical people. In information technology is brought together, that not only that expertise, but our data centers, everything is brought together to bring the cost of delivering that type of background or enabling activity at a lower cost, so that the organizations can focus on taking care of people at the highest quality and the lowest cost.
Judy, so much happens, through the years, and it's hard to say, fortunately, unfortunately, even like wartime is disastrously as that all is. We also learn, though, from battlefields and people that are getting hurt. And the questions that are coming up today, morally, in a sense, medically morally. I know myself, I wouldn't even have dreamed of them when I was back in pharmacy school or whatever. But, all of a sudden, we're faced with a lot of questions. What are some of the questions that that we're dealing with today morally, and or maybe even in the future? What do you think we might have to face?
Well, I think the issue is that technology is surpassing our ability to ethically handle what can be done and what can be done safely. There's so much. You can go to the absurdity of cloning, et cetera. There's the ability to do that now.
Sure.
The genome is mapped. We can do genetic re-engineering. The genome is mapped. It's just too expensive. But for those who can afford it, is there going to be a caste system that gives us some moral dilemmas? If you can afford to get your genome mapped and identify what gene is causing your problem or your disease or your cancer, do you get something that someone else doesn't? They're the types of questions that I think we're going to be confronted with that really are even extraordinarily difficult and will be for ethicists working with us into the future. And I think it'll challenge us as a social system. Is the common good really the common good? Can we do the most for the least? And the least of our people, those who need it the most. I don't know where that's all going to end up. Yeah,
and to keep God in our lives and keep God in our understanding, because we're not God. I don't care, how bright anybody is or whatever, and yet our faith respects life so much from beginning to, and yet some of the questions are difficult to even answer for some, because you say, well, what can we do to preserve that life? And can somebody, even get to the point of saying, what, all my life systems are breaking down, and almost prayerfully say, let me go, and families make decisions, and they make decisions. And you think back, and even Pope John III said, "Don't go thinking back." Sometimes you think back and say, it did seem simpler back then, and maybe not.
Simpler.
Maybe not. And yet, I love it when I talk about our mission to the poor, to maintain our Catholic integrity and still keep our mission to the poor. What do we do?
Well, I don't think they're mutually exclusive at all.
Right.
When you use the word integrity, integrity is one of our values. And we like to define it in the simplest terms. We do what we say we're going to do.
And we do it.
And we do it. And that's integrity.
And sometimes we sit back and say, how, Lord, how are we going to do it? Financial support, where does it all come from?
Well, I would say about 65% on average comes from governmental payers, which is kind of interesting. People don't realize Medicare and Medicaid, and particularly with the aging baby boomers, it's about 65% is covered through governmental payers. And then there's commercial payers, insurance companies that pay us. And then a large percentage of what we do are what we call charity care, or service cases that we don't get paid for at all. And that's the biggest challenge. How do we stay true to that? And the promise of healthcare reform is that many of those people will get covered. And providing access to those people, access for all, and keeping our doors open and having most of them covered to the most degree is really important, because that will help us to continue taking care of the poor. At the end of the day, there will always be people who are not covered, no matter how far healthcare reform goes, and we will always be available to them.
Some of the nurses, doctors, staff people that you've met, any saint stories that come out of all of those?
Stories.
Well,
I have so many saint stories.
Give me a saint story or a good story from one of your doctors, nurses that.
Well, it's going to be a member of our hospital family. Came into the emergency room, and he had passed out at home and had terrible pain in his belly, and he was in the emergency room, and the doctors were pretty sure it was an appendicitis. And some of my old nursing buddies went to the bedside, and they called me and they said, "Judy, this isn't appendicitis." And I said, old nurses, they can see things a mile away. They said, his hand's twitching. There's something wrong in his head. And we can't get the doctors to agree to do a CAT scan because everybody's so concerned about over-ordering things. Well, I spoke with the doctor, and the doctor looked at it a little bit differently. And he did have a problem in his head. He had a vessel that had burst. And, you know, today you would never know that. He was rushed to a hospital that could take care of it, was taken care of. That was a miracle. That was a miracle. If they hadn't been there, if the doctor hadn't been so open to suggestions, if it hadn't been a team together looking at this very subtle symptom, who knows what would have happened? And he's a pharmacist.
Gotta be careful with these old pharmacists, guys. Judy, you know, when you daydream a little bit or think about hospitals in the future and our option for the poor,
Mm-hmm.
I mean, do you see that always continuing? And what do you think of some of the, what's on the horizon? I mean, you know, what kind of operations could we have in the future that we'll have in 3 hours and go home and play golf?
Almost everything.
Everything.
My ideal is that hospitals are empty, that they're only there for the very, very sick, that we're taking care of people where they are, that we're meeting them where they are in the communities where they live, trying to keep them as healthy as possible. In the urban centers, focusing on diabetes, obesity, the things that are really bringing them into the hospital too late. So my ideal are empty hospitals and very active communities.
And that's starting to happen, isn't it? I mean,
It is.
some of it by nature and nurture. I'm also trying to think, you know, when you and I were fortunate enough to go to Africa, and when you were over in Africa, did you pick up any like thing and say, gee, you know what, these folks here without all the technology are doing some of the things pretty well?
Yeah, that was a real life-changing experience for me to see how people are cared for, particularly obstetrical care. You know, obstetrical care became institutionalized because there was a hospital to do it. Otherwise, in most countries, you don't deliver. In a lot of countries, I should say, you don't deliver in a hospital, and you deliver safely with midwives and you know, very extraordinary and exceptional bedside care. But at the end of the day, we deliver in hospitals, and it's become very institutionalized. But just looking at those differences to me was kind of interesting.
That was a trip of a lifetime.
It was.
We'll have to continue that conversation some more. Catholic Corner, you know, be proud of all the work that we do for poor, all of our faiths and all of the love, and pray for us, work with us, and just know you're loved very, very much. God bless. Thanks, Judy.
Thank you.